All right, everybody, welcome. Thank you so much for the people who are attending in person. Really appreciate you coming out. And greetings to everybody in virtual reality world over on Zoom. I can't see you, but I feel your presence and hope you enjoy the presentation. So I have the honor and privilege to present on some data project funded at the Clinical Pain Research Laboratory as part of the Miami project, a TBI study. This is part of a larger study where we used pain as a separating variable in TBI for chronic pain, no pain, and healthy controls. There's neuropsychological measures, psychological measures, pain measures, and we also did imaging studies that were at various levels of completion and submission to various journals. So this paper is actually submitted, and we're waiting to hear back from the journal to see if it's been like first round of revisions. So fingers crossed. Hopefully, we'll have details to follow. Perceptual and motor skills. Yeah. So the title of the talk is Neuropsychological Function in Traumatic Brain Injury and the Influence of Chronic Pain. So as some of you may very well know, traumatic brain injury is a notoriously heterogeneous condition that presents with a multitude of symptoms. So we have neurological symptoms, psychological symptoms, the whole suite of things that can happen to an individual over time based on the severity of their disease or the severity of their injury. So just as a point of contact, I've looked at data from the past couple decades, and earlier around the turn of the century, it was estimated that about 1.6 million people were annually experiencing traumatic brain injuries of various severity. Of those, 800,000 required outpatient treatment. And this is back, like I said, around the 2000 era. And that 52,000 deaths occurred as a result of this, and 80,000 required permanent neurological disabilities. Fast forward a couple more years, about 5 more years, it's estimated that 2.5 million people are annually being diagnosed with TBI. 69,000 deaths occur and 223 require hospitalizations. What's important about this is there's less data in chronic TBI stages, and that 35% of the deaths that occur as a result of TBI is actually self-inflicted, so it's suicide. So there's a very strong psychological component with this disorder that requires intervention that's not being met. Furthermore, 3.2 to 5.3 million people are currently living with a severe disability as a direct result of their TBI. So this is a pretty substantial health burden, both economically and for caregivers and things of that nature. So it definitely needs more, we need more research in this area. Okay, so a little background. Traumatic brain injury is a destabilizing neural event which often provokes a myriad of somatic, cognitive, emotional, and behavioral consequences. It's often difficult to predict. There's initial bedside assessments. Very much used is the Glasgow Coma Scale. So this is a bedside assessment where you assess the patient's responses to various stimuli. So you can see here there's various degradations of eyes response, motor responses, and verbal responses. You can see here that mild to severe categories are classified with higher numbers indicating less severe condition and lower numbers indicating a more severe condition. Also, things that to take into account when you're looking at initial assessments with severity could be loss of consciousness. So how long is it? Under 30 minutes? Is it 30 minutes to 24 hours, or is it greater than 24 hours? This can be a benchmark. Also amnesia. So we're talking anywhere from, under an hour or a day to greater than a week, greater than 7 days is another benchmark. And then also, when a patient is brought into, let's say, an emergency room, you can do follow-up diagnostic testing to confirm severity, such as CT scans and things of that nature. There seems to be a burgeoning area of research that is increasingly using various imaging modalities to assess TBI. And as I said, this data set is part of a larger data set that is using magnetic resonance spectroscopy and diffusion tensor imaging to look at these different aspects. All right, and please, if you have any questions, please let me know. Okay, so when thinking about how TBI could potentially present, we have primary injury characteristics and secondary injury characteristics. You can think of primary injury characteristics occurring from the initial tissue damage as a direct result of the trauma. So this can be focal, which is in a given area or perimeter, which is more compact or regionalized, or more diffuse, where the injury or the damage is spreading, large swaths of neural tissue through various portions of the brain. You can have coup, counter coup type injuries where, the initial impact and then an area in another portion of the skull is impacted as well, causing brain damage at various points. Obviously, cell death can occur here, and you also can have glial, not only neuronal cell death, glial cell death, and then hematoma, epidural, subdural, or intracerebral hemorrhage can occur. And obviously, the nature and severity of the injury is based on, one of the things would be the nature and how global the tissue damage is, both within gray and white matter. So primary injury directly result of the initial trauma. Now, you can take this further, and usually this occurs within, like right after the injury. As we start to shift to more secondary injury characteristics, you're seeing the biological cascades that are occurring as a result of the primary injury. So you can look at persistent alterations in the tissues that result from hours to years. And might I add that there's not as many studies looking at chronic TBI years after their injury, especially with pain. So I think that's a strength of the current study. Things that we can expect. So we have necrotic tissue in that given area that can be followed up with excitotoxicity, mitochondrial dysfunction. So there's various metabolic processes that start to deteriorate as a result of the necrotic tissue. You also have reactive oxygen species, reactive nitrogen species that lead to oxidative stress, lipid perioxidation, breakdown of the membranes, and also a whole suite of neuroinflammatory factors that span, interleukin, tumor necrosis factor. All of these players are going to dictate how these nerves in the damaged area not only can deal with the stress, but then repair themselves or have permanent damage. So eventually what you find is axonal degeneration and eventual cell death, widespread depending on how severe. So I like this graphic. This was used, this is adapted from Wang 2013. So you can just think of this as a general outline, a schematic, right? So we have the specific protein biomarker concentration. You have the injury, which is indicated by the pink bar here, the vertical bar. And then we're looking at cascades of events neurologically that occur immediately post-injury. So you can see from minutes to hours, we see some necrotic tissue forming, and then it starts to drop off. We also see an increase in axonal injury. And once again, depending on the nature of and the circumstances of the injury are going to dictate how widespread in the regions of the brain tissue that are damaged. And we know from, like, let's say, non-penetrating TBIs that the percussive forces and fluid dynamic changes that occur as a result of the high impact can put, let's say, white matter at greater risk for shearing and things of that nature because of the force moving through the brain tissue. So we can see here that the axonal injury kind of drops off after a couple of days, theoretically. And then we have an uptick in the cell death along with an uptick in glial cell and microglia activation. So you'll see that paired with a gradual breakdown and demyelination over time. Now, what we think about with regards to pain, is there some kind of structural maladaptive process that's going on that's making the pain persistent over time? So is there a relationship with initial brain damage and then the neural changes that are occurring as a result years later that are potentially influencing pain and cognition and things of that nature? So neuropsychological function, why do we care? Previous studies, both in civilians and in military, have noted documented neuropsychological deficits across various domains. We chose attention, memory, and executive function because we thought these were major players for people with their activities of daily living, things of that nature, occupation. These are key domains that are used in daily life. And this is just kind of a representation that it may follow a different trajectory based on the individual, and that oftentimes with mild injuries, we see a rebound in many of the symptoms, whether it be motor pain or psychological, cognitive, but then in more severe, moderate cases, we can see persistent changes that last for up to years. So things to consider: how is potential deficits or changes in attention, memory, and executive function going to impact independence, requirements for caregivers, and what's the interaction of other comorbidities? And specifically for this paper, we're talking about chronic pain. So that's what we're looking at. Okay, I'm not going to go into a full analysis of this, but I think it's beneficial just to kind of outline briefly the major players that we think are involved with this. So chronic pain and TBI, as I said, is not as studied as could be other disease processes. It wasn't, I mean, previously we'd looked at the effect of acute pain or, other researchers, acute pain, musculoskeletal pain, things like that. But very few have looked at chronic pain symptoms. Even fewer have looked at neuropathic pain symptoms in relation to chronic pain. So what we did find, there was a landmark study by Ophik and Defrin in 2007. This was one of the first characterizations of chronic pain symptoms in TBI. And they did various assessments and provided some fruitful data. They found extent allodynia, hyperalgesia, and windup. For those of you who aren't familiar, allodynia is going to be a painful stimulus evoked by a stimulus that wouldn't normally evoke pain, whereas hyperalgesia is like an exaggerated pain response. And then windup is where you apply certain stimulus over a short period of time, and as you continue to provide the stimulus, the pain increases in its intensity. So we see this from time to time across various disease populations, but also we have seen this in TBI. The one thing I want to emphasize here is that as we progressed in our understanding of pain, chronic pain, we're more and more affirming that this is a multidimensional construct. So as you can see here, if we're looking at pain perception, the left figure of the cortex here, you can see in the brainstem, you can see ascending information that's traveling through the brainstem, talking to the para-aqueductal gray, sending information to the cerebellum, and then up through the thalamus. Thalamus is going to send proportion that information to various spaces. Like, for example, the somatosensory cortex is going to help delineate duration, location of a given painful stimulus. The anterior cingulate may have to do with the unpleasantness of a stimulus or memory linked to the limbic system. And then also we have the insula cortex, which is going to be involved with the intensity of the pain, the emotional significance, even it's like thought to be involved with self-reflection. So how that pain is occurring to the individual. Now, so that's pain perception. We see widespread ascending information from the bottom up, some feedback mechanisms, but culmination lighting up the neocortex and the frontal cortex area. If you look at modulation, you'll see much more modulating effects from both cortical and subcortical structures serving as feedback mechanisms to either appropriately relay the information provided by the noxious stimuli, or if in a maladaptive model, might exacerbate a pain given a given stimulus. So you can see here, para-aqueductal gray is going to feed back, that's involved with endogenous opioid release, as well with basal ganglia, the insula. All these things are feedbacking and modulating the overall experience or the pain perception as it culminates in the individual. But once again, I want to stress that this is more of a mechanistic, right, and a schematic interpretation, but it's important to stress that pain is an emotional and cognitive, has emotional and cognitive dimensionality as opposed to just receptor activation and then experience. Usually, that's a good question. So they asked how, Dr. Sagan asked how they measure windup. So you typically take a brush and you'll start to, in the painful area, brush increasing, go, a few times in repetition, and people usually start to report if there's no sensation or minimal, it'll start to increase in intensity. And in my short time here, I'm started in February of 2022. I've come across various cases, and I've heard of cases where it's just, can be very difficult for people with the windup, especially even to the point where they'll cover themselves with, barriers to not even have any sensation on those areas. So, yeah. But so that's typically the way that I've read about it and what we've done in the past as well. Typically, yeah, so like when we do it, we'll do a non-painful control area. So maybe like a face or cheek, and then on the painful area. So that's one way to assess that.
With migraine, which happens to a large number of TBI patients, you consider neuropathic pain?
So oftentimes the neuropathic pain, it's going to be based on the descriptors when it emerged, things of this nature. I would wonder if it's neuropathic, if it's meeting a pain profile or a phenotype that we've classified in our lab in the past that would indicate that it's more neuropathic in nature. But also, is there a psychological component? And it's a good question because, cranial nerve damage can have a whole nother area, like.
I'm sure your grand's on it right now. Just popped in my head to ask that question.
Sure.
I didn't consider it, but I just thought I'd ask.
Yeah. So usually what we see here, the most common pain that, typically occurs in traumatic brain injury is, head pain, this post-traumatic headache, persistent headache. So that's the preponderance of evidence says this is the most common symptom, but as you'll see in other studies that just doesn't stop at headache. So for example, that Ophik and Defrin paper, they found bilateral with neuropathic qualities that the patients reported, and head pain wasn't necessarily the most prominent area. They actually saw it in some of the lower extremities like the foot and things like that. So yeah, good questions. And then just like a little, I think this is interesting. As we've conceptualized pain, it seemed that around the turn of the century, 1800s, 1900s, there was something called specificity theory, which is from Greek tradition, where deformation of a given unique receptor within the skin would cause instantaneous transmission of that information to the brain, where you'll have the conscious awareness of that perception. This didn't answer a lot of questions as we progressed and literature started to build. They thought maybe researchers started to move away from maybe just like receptor experience to a pattern response. So maybe there's a dynamic interaction of the intensity of the stimulus as well as the culmination of what pathways are being lit up during that particular stimulus. So there's a pattern that causes the pain perception. That still it left people wanting with some questions. So things like, why does pain occur in an area without damage? Why does pain move about over time? Why does certain treatments that would typically work for one condition and have an indication not work in others? So there was some gaps. So this led to everybody, more famously the gate theory. And then from there, which I like, and I'll talk a little bit more, and how I like to conceptualize pain at least somewhat, is the neuromatrix, the body neuromatrix. So this takes into account the biopsychosocial nature of pain. So it's not just tissue damage or potential tissue. It could be potential tissue damage. And there's this whole suite of other affective components, cognitive components that can ultimately influence the way pain is being perceived in the individual. So this is what I'm talking about here. So this is from Malzak. It's adapted from his 2001 paper. And you'll see that there's inputs and outputs to this body self neuromatrix. So basically you can theoretically see a specific neurological pathway or structural schematic being excited, and then you'll see a correlate of an experience, self-report, maybe a certain quality. So these things are interrelated. He specifically broke it down into cognitive evaluative framework. So tonic inputs from the brain are going to influence the way you perceive the pain based on cultural past experiences, personality variables. For example, somebody that might be more open might have a different pain response to somebody that's less open as one of their personality traits. There's also phasic input from attention, expectations, anxiety, depression. So these are all things to consider. There's also a sensory discriminative. So this is going to be just where the pain is coming from, and being able to differentiate those sensations as they're coming into consciousness or rising in consciousness. And then you have a motivational affective, which is influenced by various subsystems like the adrenal system, immune system, cytokines, endogenous, opioids. These are all going to feed into the way that the pain experience is ultimately perceived. So you have pain perception, action programs. So this is involuntary actions or patterns of muscle action that might help people deal with pain. And then if those are identified, then self-regulation programs that can keep those action programs going. So you can see over time, these things are constantly working it with one another. And the emphasis has changed now to that pain is multidimensional in nature and requires the cognitive, sensory, and motivational aspects. Okay, so our hypotheses. Basically what we thought would occur is we hypothesized that people with TBI and chronic pain will perform worse across measures of attention, memory, executive function when compared to their non-pain counterparts and healthy controls. So this is a 3-group comparison. Pain severity will be significantly correlated to psychological symptoms, and that post-concussive symptoms, pain severity, and poor psychological health would predict cognitive deficits. So multiple things going on here. So right here is just real quick snapshot of the sample, 26 people with TBI and reporting at least moderate pain. We compared that to TBI with no pain or not chronic pain symptoms, and then healthy controls. So a total of 86 people, and compared them across the dimensions of the various cognitive dimensions, pain dimensions, and psychological dimensions. So inclusion criteria: male, female between the ages of 18 to 53, fluent in English, have chronic TBI for 6 months. And like I said, this is a population that's lacking in literature. I mean, there's still a lot of work that needs to be done. So any information that we can add is going to give us a starting point for follow-up research to innovate, therapies and the next step. So exclusion criteria, very important here. We limited people that had severe cognitive impairment. So people with a MMSE below 18, we excluded. This is done because, that can make some of the assessments very difficult to complete. There was also, as part of this initial protocol, to spend time in the MRI, and things like that. So people that might not be as, have more impairment might find those tasks difficult, and as researchers collecting that data. We also screened for recent alcohol abuse, drug abuse, major depression. So this once again can make certain assessments difficult to capture. So we excluded people that had a Beck depression inventory above 29, which is the cutoff for severe depression. And then other systemic neurological diseases, so like MS or something like that, Huntington's disease, they'd be excluded. We did collect, when possible, Glasgow Coma scales, and then River Mid Post-Concussive Symptom Questionnaire we also identified. Okay, so attentional memory and executive function composite scores were generated based off several subtasks that were then added and divided by the number of tasks to give us an overall composite score of that domain. I think this was important because you're looking at each domain from a slightly different angle, and that's going to increase the robustness of our findings. So for attention, the attention composite, and this was also loosely based on previous studies that use this approach. I should also mention that raw data was converted to T-scores, normalized to account for any variations in, age or baseline characteristics. So we use their T-scores standardized. Now, the trail making test A, if anybody's unfamiliar with this, this is a task that requires the individual under time circumstances to connect several dots in ascending order as quick as possible, with these numbers indicating the path. And it's scattered over a sheet of paper, so it's almost like a maze trace, and they're timed. This is a visual processing speed attention on time on task. We also used the Wechsler Adult Intelligence Scale, the 4th edition, comprehensive neuropsychological battery. We selected the coding and symbol search. Once again, this is visual processing speed attention, where in the coding, the participant is given a series of symbols and then subsequent lines, and under time conditions, they need to see within the subsequent lines if the symbols match, and they indicate if there's an error, if there's a mismatch, or if the symbol's present. You can count the errors. And then the symbol search is asking the participant, once again under time conditions, to see if any of the figures presented on one side of the task is simultaneously in the other side of the task, and they can indicate. So this is like allowing them to seek out and attend to any differences that they see during the task. The memory composite was based off the brief visual memory test revised. So this was where the experimenter will provide the participant with a series of drawings, which they are then subsequently asked to recreate. And there's a delayed portion 25 minutes after, where they are subsequently graded based on how, predefined rubric, how close they are to the actual number, shapes, etc. So this is a good measure of like a pattern or shape memory, so a little bit more specific, as opposed to the Hopkins verbal learning memory test, which is under time circumstances, once again, that they are given a series of words in separate trials to see if they can remember as many words as possible. So we're looking at actual like pattern recognition and then verbal recognition. So it gives us a nice blend of memory measures. And once again, this has a delayed component as well to see if they remember the initial list of words. It's a nice score. And then finally, we have executive function composite, which is the trail making part B. This is similar to the first one, only there's an additional rule of ascending alphabet. So they have to add that additional rule, set shifting. You could think of it as an additional challenge. That executive function processes theoretically are thought to govern. So, and then finally, the controlled oral word association test, or the COWA. We had 2 versions of this, semantic and phonomic. So the phenome is based on the spontaneous generation or verbal fluency this person can present when given a certain letter. In our cases, it was F, A, and S under time circumstances. How many things can you name starting with letter F? they continue. Then we also did a semantic where we asked them name as many animals as you can. So this is a verbal categorization and then a specific constraint on the allowable characters based on a given category. So we're getting two nice little measures of fluency paired with the additional rules-based trail making test to give us some proxy information for executive function. Also, for pain assessments, we use the International Spinal Cord Injury Basic Pain Data Set version 2 modified for TBI. This allows us to follow up to three concomitant pain problems, measure intensity, duration, descriptors. So to your point, this would be this is a great tool for us to document any canonically considered neuropathic pain symptoms or the quality of the symptoms. We can document it here and the location, very useful. We also use the neuropathic pain symptom inventory. This is specifically used for neuropathic pain symptoms over the last 24 hours. So this is going to be things like how intense is, do you have any burning, electric, things of this nature, spontaneous painful attacks. And this is a good measurement of neuropathic pain symptoms. And then finally, we used section 1 of the multidimensional pain inventory, the MPI. This is an assessment that not only measures behavioral and psychological domains of pain associated with pain, but also like interference with activities of daily living, things like this. And then what we did is we took pain severity by summing and averaging 3 different questions or items from this scale to give us that pain severity value. And this has been done in previous studies by our lab. Okay, psychological assessments. Like I said, we did the Beck Depression Inventory 2, Beck Anxiety Inventory, and the PTSD checklist. So as you'll see there, severe depression values were used as exclusion criteria. We looked at this demographically, their demographic information using chi-squares, independent samples, Mann-Whitney U tests. We also used multiple one-way ANOVAs to assess attention, memory, and executive functions across the cohort. Looked at correlations between psychological, cognitive, and pain variables within the pain group, the subsample, so the 26 participants. And then we did stepwise linear regression in the sample to determine potential influence of chronic pain and post-concussive symptoms on cognitive function and psychological health. So trying to get some semblance of how these things are interacting with one another. Of course, a priori, all tests of significance were preset at an alpha of 0.05. Okay, so what did we find? So pretty interesting, no significant difference here with males and females, which is good from an actual design perspective. We're not going to have any effects there. Age, you see is pretty close across, not significantly different there between the groups. Ethnicity also not significant. Now, years of education, significantly different. 2 things I want to bring up. You can see that the years of education is about a 2-year difference between the no pain and pain group. So I'm not sure the influence or how impactful this, even though it is significant, will have on overall neuropsychological values, given that it's maybe the difference between high school and associate degree, let's say. The MMSE was also significantly different if you look closely by less than a point. So statistically significant. However, when using this assessment, even as a screening criteria, you'll see it could be literally a difference of remembering 5 words in one condition and 4 words in another condition can separate these people from one another. So how sensitive this difference is, I don't know in the long run. And then the Glasgow Coma Scale we can see is actually significantly, not significantly, but worse in the no pain group. Now, one thing I'd like to bring out here is that we were only able to obtain a portion of the Glasgow Coma scores for our sample when they were enrolled into our study. That being said, so that limits potentially any group comparisons we can do based on injury severity per se. So based on this measure. Now, we can, as a proxy, use the RiverMed scores. So these are the RiverMed post-concussive symptoms questionnaire. And this is follows several symptoms over time related to concussions. So we kind of use that as a severity, or we did use that as a severity measure as a proxy. Age at TBI, very important. I'll follow up with this later. Significantly different. 22 years old of age for the no pain group on average versus 30 with the pain group. And then once again, trying to control for that using the standardized test scores, the neuropsychological evaluation. And then finally, you'll see that there is a significant difference in the RiverMed score. So there's something going on with the experience and severity of post-concussive symptoms between the 2 groups, with the chronic pain group reporting worse concussive symptoms. or post-concussive symptoms. And then also consistent with the literature, you'll see that the most common cause is motor vehicle accidents. Okay.
Done when the patient is first seen or when the patient is evaluated?
So we are going to go back and try to find the data. Some of the people, when available, would provide their initial Glasgow Coma Scale, but when we didn't have that, we admitted them anyway, and then did the River Mead as well. So. Right. And that's one of the obviously limitations. I'll touch on that again. That's just something with the data that we have. So hopefully future studies will be able to control for that a little bit better. So yeah, most common cause, motor vehicle accidents, consistent. So distribution of pain, most common symptoms, consistent with the literature, head pain, neck pain, low back pain. So 77% reported pain, although it might not be canonically considered neuropathic in nature, we did see sharp aching and throbbing pains at these sites. So it's definitely a problem here, and people are reporting, a good amount of suffering because of these symptoms. Okay, so here's the results from the multiple ANOVAs looking at between groups. Interestingly, and inconsistent with a lot of previous literatures, we didn't find any group differences in attention scores. I can't account for why this happened, but they're pretty close. The clusters are pretty close, and we couldn't find any statistical anomalies here. What is interesting and is consistent with literature is that we saw significantly worse memory scores in the pain group. Specifically in the composite score, pain group was worse than controls, not significantly worse than non-pain. In the verbal or the visual delayed recall score, we saw worse performance in the pain group compared to controls. Then in the verbal, we saw both TBI groups compared to controls performing worse significantly. And then finally, in the delayed recall of the verbal, we saw once again the pain group performing worse. So there's something going on potentially here with pain, the variable of pain, and then memory values that we obtained. Coincidentally, or it's kind of interesting, when you look at the executive function composite, and contrary to our initial hypotheses, we did not see worse performance within the pain group. We actually saw worse performance within the non-pain group. So they did worse on the composite. They also were trending significantly worse in the phonomic fluency. So this is like spontaneous generation of different objects or categories of objects starting with different letters. And then we saw that the semantics, so the animal categorical information as far as calling that up, was significantly worse in both TBI groups compared to controls. So although there was a little bit of each, almost like a yin yang of deficits in the memory and executive function scores that we obtained, with the pain group performing significantly worse in the memory and the executive function being performed significantly worse by those without pain, there is a little bit of deficit in the other. So that we did see some deficits for the non-pain group in memory, and we did see some deficits in the pain group for executive function. But there is a kind of an overarching domain-specific deficit based on the way we partition the groups in the presence or absence of pain. Okay, so looking at the regression here, when I ran the whole model together and looked at correlations, I only found one actual correlation between those with TBI, cognition, and psychological symptoms, and it was anxiety and memory scores. So subsequently, I went back and looked at the pain group alone. Admittedly, this is a smaller sample size of 26 people, but what we wanted to look at, since I wasn't finding any major correlations between cognition and pain, or cognition and psychological outcomes, there was a very tight association, and this is consistent also with the literature, between pain and various psychological symptoms. So in this regression analysis, I've actually found that River Mead scores, so this is post-concussive symptoms paired with pain severity, most accurately predicted depression inventory scores. So, explained a significant proportion of the variance. Then differentially, so we found that River Mead scores and neuropathic symptom inventory total scores predicted anxiety. So there's something potentially going on with anxiety and the qualities of neuropathic pain versus pain severity per se linking with depression. And then finally, we found that really pain didn't have much impact on PTSD with our sample. So mostly being predicted by the River Mead severity. So pretty interesting findings that severity versus neuropathic symptoms differentially predicted depression and anxiety. Now here, this is a good depiction. You'll see those in the pain group significantly worse across the depression, anxiety, and post-traumatic stress disorder. Now that there is some things here, a caveat to say, we don't know the extent of the relationship in people with severe depression, and we don't know the extent of the relationship with people with minimal pain or below our cutoff score. So there's some at the tail ends of the distribution, we're not accounting for that data. So these, once again, looking at maybe more mild cases with between mild and moderate pain and high depression would be an interesting thing to look at here. Yes, I believe so. Yeah, or I think it's standard error. I'd have to go back and check. I have to go back and yeah, I'd have to go back and look. I think it's standard deviation. I think that's what it is. I'm almost certain. Of course, yeah. So there's multiple things to talk about that we didn't directly assess. Obviously, people are going to deal with pain in different ways, and this is even in the study that I'm running right now with a multimodal intervention to assess pain. Some people are able to ignore it. Some people are able to use changes in position. Some people are able to or have better self-efficacy. Where the rubber meets the road is how the person is experiencing the pain and what the intensity of the pain level is, I think, and the duration. So people maybe perhaps with more of a predisposition for catastrophizing might put themselves in a situation where there's this constant feedback loop of waiting for the next painful attack. So it's kind of hard to break out of that, as opposed to somebody saying that might be considered to have higher self-efficacy, that this is not something that's happening to me, but something that is going to happen, and I have a way to deal with it. I have some semblance of ability to impact the way that I am dealing with this. So there's all these things from genetic predisposition to catastrophizing to self-efficacy to cognitive behavioral techniques. Coincidentally, more and more literature is being done with pain and mindfulness, which I'm also very interested in. This is just a form of psychological skills training. So did that answer your question, or? Right. Yeah, just for the purposes of this study, we didn't measure that, but that's definitely a big factor that I keep seeing recurrent in the literature as far as the way people are managing their pain. So basically what we saw is that head, neck, and low back pain were the most commonly reported symptoms. Pain seems to be involved somehow with the memory process, where I like to think of it as almost like an etch and sketch. So during the tasks, the patients were able to dial in the lines. They were able to filter the information that was coming in, and they were able to complete the tasks. After the delay, that etch and sketch was shaken and there's nothing left. So maybe, or not nothing, but less poor performance on the delayed portion. So what may be happening is that there's not a maladaptive mechanism involved directly with the encoding process, so the way the information is coming in, but the way it's weighted and consolidated within those key memory centers, there might be some damage there, some mechanism responsible for why we saw poor memory performance in those with pain. And then when looking at executive function, no changes in attention between the groups, or no differences rather, but there was marked differences in fluency. So something's going on with this metacognitive process of ability to, pull up spontaneous information based on a given set of rules. So there's something maybe happening, most likely, I would say having to do with severity, but once again, as a limitation, we don't have Glasgow coma scales, as a way to parse them, but we do have River-Mead scales, and we do know that is contributing at least to the psychological symptoms. And then finally, there's one other thing I wanted to say. Anyway, so there could be a multitude of things going on, but this is just very interesting that pain showed a direct response in memory performance, whereas those with no pain showed marked executive function deficits. And that I remember what I wanted to say. So one potential thing, in which I brought this up earlier, is that if you look at the age at which the TBI occurred, I'm not saying this is definitive, of course, this is just a speculation, but the average age was 22 versus 30. So 22 in the non-pain group versus 30 in the pain group. And apparently we see this in spinal cord injury as well. Maybe that there's something with the ability of the body to bounce back in younger age versus older age. Maybe there's something going on with the normal neural developmental process where damage earlier in life might have a more implications for certain cognitive domains over others. So could be that, maybe those higher order faculties that are thought to be culminated in what would be called executive functions were damaged before they were able to reach maturity, which then has lasting impact years after with executive function deficits in that group. So basically, limitations, once again, didn't have the Glasgow Coma scores for everybody. There was some demographic variation. However, we tried to cover for that with the neuropsychological testing using the T-scores. We didn't have the severely depressed as part of the cohort, and we did not have people with minimal pain. So these are both future questions to be answered. So in conclusion, those with TBI exhibited cognitive deficits compared to their pain-free controls. Those with the pain group performed more poorly on visual spatial memory and verbal memory and semantic fluency tasks, while also exhibiting worse psychological symptoms, whereas those without pain did poor on measures of executive function, but lacked those psychological variables or the severity of those psychological measures. So these are all ripe to be examined in the future. And we are actually, as part of this data set, like I had previously mentioned, we're looking at metabolism differences using magnetic resonance spectroscopy at various brain regions thought to be involved with pain processing. We're getting ready to submit that actually tomorrow. And then we have a follow-up study where we're going to be looking at DTI to look at tractography and how that relates potentially to neuropsychological variables in this group with the available data we have. So plenty of things to look at and many exciting future avenues to proceed with. So just want to thank everybody and thank Dr. Ava Widerstrom-Noga for allowing me the opportunity to integrate into the Miami project and her lab. And thanks for everybody being here and my lab mates, and hope you enjoyed the talk. Thanks.
Do we have any questions?
MRIs by any chance?
Yeah, we do, and we're processing that data now. So we actually do have in a subset of the sample magnetic resonance spectroscopy that we're using, and then we're going to be using those same data to get the DTI. So we're going to be looking at the metabolism, but not like the actual, just structural.
Yeah, really nice to see cortical versus subcortical.
Yeah.
Hey, you look at this would be a great study for PTSI, where we're looking at diversity in different types of populations, subjects, and I think there's a lot of literature now on diversity being a independent variable for how individuals respond to injury, as well as their ability to see clinicians and actually be treated properly. So these are the type of things that this particular research program could be expanded into, because that's what University of Miami through the CTSI is funding these days. So it's a real important area. Did you look at sex? Did you look at male, female?
Well, I didn't look at differences. There's no statistical differences between the groups. No, there was. We were pretty, I was actually very excited to see that we were pretty close, males to female ratio. So I can put it.
So the number of.
But I didn't look at within group based on gender. I did not, or sex. I didn't do that.
I see.
I could. You could look at that.
That's another kind of hot area now that many people are looking into. And what was the third thing I wanted to say? I guess you didn't look. I'm sorry, you didn't look at migraines
they didn't care. So the available data that we had, they didn't characterize it as traditionally migraine type pain. So this was, I think, actually another interesting point is that our pain distribution and symptom and the quality of the symptoms are different than previous studies. So with the majority being, headache, I see often, but this is going to give us slightly different information.
Photophobia is a major, I'm just thinking about what I've been reading recently in terms of major consequence of TBI. Did you look at any visual issues that could have affected their ability to do what the tasks that you're asking them to do? I didn't, and that is a great point. It reminds me of like when I was doing my dissertation, I was part of it was looking at executive function measures, and part of it was a Cherup task. And I realized that one of my advisors was colorblind. So I didn't even realize, before I was like, oh my gosh, you're right. I got to test these people for color blindness. So that's another important, similar thing.
Good talk. Thank you. That was great.
Oh, thanks. Appreciate it.
Any other questions?
I mean, to get to the migraine thing, you could see if they're taking medications for migraine, or you can sort of parse that out, like if they're taking a triptan or something like that.
I think a lot of times with the migraines, they like think of it as pressure and throbbing and things like that. We do have throbbing here, but it's, sharp and aching is more the qualities that we saw for this group.
I mean, I would just look at the medications, because they would tend to take medications, let's say. So I just curious, do you think this is a chicken and egg thing? Like, what, is the pain leading to the cognitive issues, or vice versa?
So I've thought about this, and this is retrospect. Obviously, you think of the things that would help the study make it stronger, but obviously another time point would have been important here if we could have captured one. So over time, a strength of the study is that we have values that are years living with TBI, which we haven't seen as many studies looking at. But if we could actually look at their trajectories by having at least one more data point, we could have did maybe a mediation moderation analysis and looked how things are impacting one another. And that would be a very interesting question. Something that I would really look forward to.
If you could do some cognitive training on them, would it alleviate their pain? Or if you alleviate their pain, would it help with their cognitive? You know what I mean? Like,
I think that's part of the problem of this population, is that there's a lot of variability, a lot of heterogeneity. People experience their pain symptoms. People experience the symptoms from their trauma differently. I do think, and this is based off my advisor, my mentors, own philosophy, is that pain is processed in the brain. So theoretically, if we take that as our first principles, we should be able to modulate the way that pain is experienced if the proper tactics, skills, or training are applied. If everybody experiences pain in the brain, there should be a way to at least examine how those triggers are coming about, ways to mitigate them, and then individualized techniques that might be able to make that pain at least manageable, so that they can go out and do their daily activities. I think that's so based on study I'm running right now. There's a difference between people that have a rating, pain severity of 4 out of 10 versus a 7 out of 10. And there may be a threshold there where you can't just ignore it, But as far as I think it's a very complicated, multidimensional construct, but I do think if it's experienced within the brain, that we have an ecology of practices that can be potentially exported or implicated in helping to address how these people are dealing with their symptoms. For me, it's, I'm also a yoga instructor and I've done mindfulness studies. So I'm very interested in that approach. So.
Yeah, great talk.
Thanks.
So one question, and this kind of goes with what Dietrich was saying with the cognitive testing. While you're doing the cognitive testing, do you also assess for any symptomology while they're doing the test? Because someone could perform maybe equally as well as someone without pain, but it could increase their symptoms while they're completing the task. So I wonder if that's something that, I don't know if that's been shown in the literature or
I know that, there's distracting, stimuli and stuff that they use, when putting people in scanners to try to see how that modulates the pain response. So I know that there is evidence to show that the presentation of various stimuli can undermine how the people are experiencing pain. I think that I saw this in healthy people, the paper I'm thinking of, but where it was the laboratory induced the pain. So this isn't the same as chronic pain. So there might be a different, thing going on there. But I absolutely think that would have an effect. And I think that's just the nature too of, clinical research. The people come in on the day that they come in, and some days might be worse than others, you hope, but who knows? I've had people doing pre-post testing where they come in and it's worse than they came in before. And you see people that come in better than they were before. So I think a lot of it just is individual variability, and take it from there, But obviously, I think if somebody was having a pain day, a neuropathic pain days, let's say in that sample where their pain was an 8 versus, somebody else in that same group whose pain is a 2, probably I'd be willing to hedge that had some effect on their ability to trace circles in ascending order properly.
Yeah. The other question is, because you saw a difference in age, with TBI with pain versus no pain, but did you look at a difference in age with a Rivermead score? I would imagine those go together.
So I did not. We did look at, but the Rivermead was once again significantly worse in the pain group,
pain,
you
yeah,
know.
that's
So I mean, that's kind of like what we used as the proxy for severity, since we didn't have all of the Glasgow scores. But I think it's a good measure. You know, it's been used extensively in the past. So, but yeah, lots of stuff to be ironed out. Many more studies to be done. Really exciting field area of research.
Yeah, my other question was going to be like, is there, because it was interesting that like the no pain group and the pain group kind of performed differently.
Yeah.
The different tasks. Is there any previous research on like the location of where the injury occurred, whether it's like the back of the head, the front of the head, the
So
sides?
that would be your, you know, the initial question would be, are people, for me at least, like let's say those in the non-pain group are experiencing worse executive function performance? Is there more damage to the frontal lobe areas, you know? Yeah, or maybe in the more limbic structures for the memory, like the hippocampus. These are things we're going to look into. But that's with a, you know, different data set, you know, because part of this too, as again with clinical research, you know, retention's, you know, hard to follow up. So some of the people we had full measures on one day of assessments, and some people didn't complete the MRI assessment. So we work with what we have, you know, so definitely things to follow up with.
Thank you.
How about treatments? What do you think about in terms of meditation?
Oh, I have ideas, sir. I have ideas. So for me, and what so right now, I think I mentioned, so I'm an exercise physiologist in training. And given that pain is a multidimensional construct, I think it's going to be a multidimensional approach therapeutically to resolve the symptoms. So not only would you have a cognitive evaluative, so matching up with the neural matrix, you'd want to hopefully target each of those subdomains with the appropriate therapy. How do you do that? I don't know yet, but I do think that some kind of psychological skills training would be beneficial. I also think that potentially in certain people, some kind of pharmacological intervention paired with that would be beneficial. And then I also think that movement, because what we're seeing now is that in the study I'm leading or coordinating right now is that people are really responding favorably to the exercise. Now, this is a circuit resistance training program, so you have to kind of titrate difficulty intensity based on how people are perceiving their pain and the, you know, the degree of their pain. But I see a study design where we would look at 3 or 4 different approaches in a, you know, a fairly short time frame, and then randomize the order of which these are implemented, and then measure track changes across time within the same people to see if there's a, you know, greater effect size for one approach versus another. If it's just kind of like a linear, you might not, you know. So right now, currently too, we're trying to get a CBD study off the ground. So there's a potential avenue for treatments, we think. And I should note actually too, that, you know, many of the people that I'm talking to that are doing their follow-up assessments, they are saying that, you know, cannabis is very effective for them to help their pain. So I would like to continue to do research on this, collect more data, but then integrate all of these approaches to see if we can get the desired effect. So.
There was a cannabis study with pain, for injury subjects that was negative in Sweden. I've been trying to get Eva Noga to look at that, and she has. But talk to Eva about Mind Maze.
Oh yeah, we have.
Okay, do you have? Okay, so you guys are on it, because I think you just mentioned, you know, exercise and things like that, and Mind Maze is specifically trying to push that in terms of whole body exercise and movements, how it can potentially affect recovery of function, and something people can do at home potentially. So that would be maybe something also to consider in the future, and Eva's already considering that. Anyway.
So, and I should have mentioned that too, as part of that. So we're talking pharmacological, non-pharmacological. I would like to see the eventual incorporation of augmented or virtual reality into this. You know, we're doing some preliminary work on getting visual feedback, you know, doing mirror illusion therapy to see if this is helping with manageable pain. So ultimately, I'd like to see a fully immersive type situation where now we have people, you know, projected legs, you know, with a reflection, you know, trying to match their walking rhythm. But imagine if you were in a completely immersive experience, you could look down and create an avatar that looks like you. What neurocircuitry is being excited with that visual feedback? You know, is there something there? I mean, we see similar things in phantom limb pain when we're, you know, people can have the pain dissipate or intensify based on the visual stimulus that they're getting. And this is also part of the other study that we're doing. So body representation. So I would like to see, and then TDCS is another great avenue. So in my mind, I would love to see like a multi-pronged randomized approach using various therapies and then measure in the same person across time, comparing effect sizes. That'd be really cool.